Okay, perfect. All right. Hi, everybody. Thank you so much for joining us this evening. I'll give everyone just a couple of minutes. I see people are logging on. So as we're logging on, we'll just go through some housekeeping items and then I'll hand it over to Hillary. My name is Brooke. I'm a speech language pathologist here at Timms Medical, and I am so excited to be co-presenting tonight with my good friend Hillary Cooper. A couple of housekeeping items. This webinar is eligible for 0.15 ASHA CEUs. We just ask that you stay for the entire duration of the webinar and that you complete a brief survey, which I'll put in the chat. And we just ask that you complete the survey between, let's see, today is Tuesday. So between today and next Tuesday. And if you can't access the link because you're on a phone or something, no worries. We will send it out via Zoom emails twice. And then if you don't receive it, just send us an email at tims-unit@tims.com and we can get it to you that way. And then finally, if you'd like a certificate of completion for this webinar, just again, send us an email at tims-unit@tims.com and we will get that custom made and sent back over to you. So with that, I'm going to hand it over to Hillary.
Hi, everyone. I am so excited to be here. So let me do some technology real quick. I'm going to share my screen and we're going to get this party started. Let's see. I promise I can technology. Maybe. I'm not used to doing view slideshow. Okay. I'm so used to PowerPoint instead of Google Slides. So So welcome everyone to Innovative Documentation Strategies for Dysphagia Evaluations. If you don't know who I am, my name is Hillary Cooper, and I'm here with Brooke to share with you a whole bunch of really cool stuff. This webinar came about because you asked for it. So if there are other topics or things that you need covered to make your life easier as an SLP, let us know. And I'll do my best to see what I can do about bringing it to you. And I know that Brooke can speak for Tim's as well. So we can't do it if we don't know what you need. So yay. This is our time-ordered agenda. We've got a lot of information to cover. And these are our learner objectives. And my disclosures, I'm the owner of a mobile fees company. I'm faculty at McDaniel College. Whoop, whoop. I'll be starting there in the fall. And I do receive a complimentary Tim's MVP software license for research and educational purposes, and also to give them feedback and help them get better, which is, so amazing. I'm also the founder and president, one of the founders and president of Dysphagia Outreach Project. I'm on the SIMI Case Advisory Board, and I've done a whole bunch of other stuff. I am on the tail end of my doctorate right now, so I have about 33 more days before I submit my dissertation for defense review, so wish me luck. I'll let Brooke.
Thanks, Hillary. So like I said, my name is Brooke. I am a member of the leadership team here at Timms Medical, and I also still practice clinically, and I'm an adjunct professor at Maryville University. And I have no relevant non-financial disclosures, but just to plug as to what Hillary said, I know a lot of you use Timms, so if you all have feedback for us, please give that to us. A lot of the features that you see in the software today are direct collaboration from clinicians using Timms in the field, boots on the ground people that are using this. So we want to hear from you. And same thing on the CEU side. We want to hear from you all, what topics you want us to cover. So with that, I'll hand it back to Hillary. Oh, and if you have questions, please feel free to put them in the chat or the Q&A. Hillary and I will be monitoring that throughout this presentation.
Awesome. So before we get into the meat of this webinar, I have to take a moment to do a little soapbox. So you all know that I am passionate about health equity. And I just want to remind everyone who's here with us, and for the people way far in the back, that health equity isn't just a patient thing. Health equity also impacts us as SLPs. And it's exacerbated by limited access to high quality education or CEU opportunities. So I just wanted to take a moment to say thank you from the very bottom of my heart to Timms University, Timms Medical, for being aware that there is such a huge gap in what SLPs can have access to because of financial reasons. And there taking the time and the energy and the effort and putting their money where their mouth is to bring dozens of hours of education to you every year for free. So I also, it's part of my mission with Dysphagia Outreach Project to bring high quality education to you guys, resources to you guys free. So that is definitely what I'm doing and what Tim's is doing to help meet that health equity issue in the SLP space. I gotta hit you up for donations, you guys. It's Dysphagia Awareness Month. This webinar was brought to you because of Dysphagia Outreach Project, because of Tim's medical. Our mission is to provide free supplies, medical supplies, to people who have dysphagia or feeding disorders. We also provide education and resources to you, the treating clinicians. We do that because you guys support us in return. So if you have $1, $5, $25 to donate, 100% of that goes to our organization. Nobody gets paid. I don't get paid. And it helps us to do things like support our website that gives you the freebies that you're going to have access to tonight. And in order for us to pay for those things, we do need money. So if you donate, it's one of those things. You help us, we help you. With that being said, I do have a bunch of freebies for you. So if you haven't seen them in the email that came with the registration link, please feel free to go down there now or later, whenever you want. Dysphagia Outreach has a shop that has a whole host of free handouts. I have my FEES template and a bunch of other stuff on there. And then also Dysphagia Outreach Project sponsors part of dysphasiainformedconsent.com, which has also more templates, freebies, and resources for you as a clinician that are at no cost. So just wanted to put those resources in front of you. So I'm going to hand it back off to Brooke. Oh, wait, hold on. Before we start. I'm getting ahead of myself. So before you start, on a scale of 1 to 10, put it in the chat. How would you rate your FEES or modified or even clinical swallow evaluation documentation effectiveness? So I don't see the chat. Any numbers? Like throw those numbers in the chat. I would love to see them. Like, how do you feel you are?
Oh, hold on. It's saying chat's disabled. One second.
Ah, well,
Well, that
there.
would, hold on,
Womp,
everyone.
womp,
Okay, now you can chat. Sorry, everybody.
Yes.
There you go.
Yes, throw those numbers in the chat and let's see what, oh my gosh, wow, there they go. So I see a whole wide range, right? So some all the way down at the worst, some 5, 6, 7, 8. Yeah, so I think it's something that we all have room to grow in. Um, and I'm continually striving to improve my own documentation. And so I just hope that by the time you leave this webinar tonight, that you have immediately implementable tools and strategies to help make you feel a little bit better with your documentation. And now I'm going to hand it over to Brooke, theoretically. There we go.
Let's see. Hillary, can you go to the next slide? Oh, there we go. Perfect. Awesome. Thank you. All right. So now we are going to transition to discussing the science of documentation, which refers to the medical and scientific study of how health information is recorded, retrieved, and managed. So as we can all attest, documentation is a critical component of the many responsibilities that we hold as speech language pathologists. And we know that accurate, complete documentation is crucial for interdisciplinary collaboration, plan of care development, insurance reimbursement, and patient access to care. Inadequate documentation contributes to claim denials, prior authorization delays, as well as interruptions and delays in care. Data from the American Hospital Association indicates that 78% of hospitals report negative impacts from insurer interactions, including increased administrative burden and delays in patient care. These findings emphasize the critical relationship between clinical documentation and insurance coverage decisions. We'll go to the next slide. So, as we know, clinical practice extends far beyond direct patient care. As speech pathologists, we must possess a deep understanding of the diverse etiologies underlying dysphagia and apply critical thinking to evaluate each patient's unique presentation. At the same time, we are responsible for adhering to organizational policies and procedures, integrating evolving technologies into practice, adapting to regulatory and workplace changes, maintaining our licensure and certification through continuing education, and contributing to education within our organizations as well as patients and the wider community. When viewed in the context of these competing responsibilities, it's really easy to understand why documentation can be a challenge for a lot of us. Yet, documentation remains one of the most important components of our clinical practice, and it directly impacts our interdisciplinary communication, reimbursement, and patient access to care. So, as we know, some of these common barriers to high quality documentation include time constraints, productivity expectations, high caseloads with limited support, lack of clarity or incomplete documentation, whether that be from, interdisciplinary team members or other speech pathologists, insufficient training on EMRs, coding, and documentation requirements, among other challenges. So while we have so many competing clinical and administrative demands, documentation may end up being viewed as a task to complete rather than a clinical skill to master. However, we do know that high quality documentation is absolutely fundamental to patient care, reimbursement, and demonstrating the value of the services we provide as speech pathologists. We'll go to the next slide. So as we know, our documentation might be read by a variety of audiences, including but not limited to the interdisciplinary team members, patients, family, and caregivers, and insurance providers such as federal programs, private and commercial insurance, and workers' compensation. So as clinical writers, it's our job to find a balance in reporting that addresses the needs of each of these audiences. So we'll go to the next slide. We're first going to discuss physician documentation preferences. And we took a look at the research to see what do physicians prefer to see in our documentation. So in order to assess effective communication for optimal medical consultation, Bulwer et al. Completed a study in which physicians with at least one postgraduate year of experience completed a questionnaire regarding medical consultation notes. Findings revealed that 69% of physician respondents preferred recommendations in a bulleted or numbered format rather than paragraph form. Separate sections for assessment and recommendations were preferred by 48% of respondents, compared with 37% who preferred organizing content by problem. 48% preferred recommendations at the end of the consultation note, while only 26% preferred recommendations at the beginning. 71% of respondents valued clear, concise recommendations supported by a brief, and I highlight brief, speaking for myself, a brief rationale. Interestingly, at least to me, references or citations supporting recommendations were actually considered low value. So next, we'll go to the next slide and talk about our community health preferences. So as we know, in addition to our physician colleagues, patients and members of the community may also be reading our documentation. Ayer et al. Conducted a study in which they compared community preferences for original and simplified health texts, in which participants reported their preferences according to understandability, confusion rating, familiarity with words, trust, actionability, and intention to share. Their findings revealed that bullet points were preferred over paragraph text for health information, because we know that bullet points may improve perceptions that information is easier to understand, trustworthy, and actionable. Further, we know that bulleted or numbered lists are actually an established health literacy strategy. Additionally, plain language made information appear easier to understand and less confusing, and simple writing strategies such as everyday language, minimal medical jargon, the use of active voice, all of these increase the perceived accessibility of health information. We do know that more research is needed to determine whether or not these findings and these formatting improvements also enhance comprehension and recall. So next, we'll go to the next slide and we'll talk about our third-party payers. All right, so we all know that healthcare is both a service and a business. Reimbursement directly influences patient access to care, technology adoption, as well as quality outcomes, and our documentation is absolutely critical in this process. Complete, accurate, and descriptive documentation is the foundation for coverage and reimbursement decisions by Medicare, Medicaid, and commercial payers. So our documentation should clearly demonstrate medical necessity and skilled intervention, patient status, goals, progress and outcomes, care coordination, education, and discharge planning. And strong documentation supports reimbursement and reduces claim denials. It improves continuity of care and interdisciplinary communication, demonstrates the value of our clinical services, and ensures timely patient access to medically necessary care. So the key takeaway here is that the quality of our documentation directly impacts reimbursement, patient access, and the ability to deliver high quality care. So we'll advance to the next slide as we wrap up this sort of introduction to this topic. We're going to quickly review the content that should be included in our reports as well as the format. So in terms of content, we want to make sure that we're talking about medical necessity, both the patient and the clinician perspective, including our clinical rationale for decisions, the rationale for treatment, as well as recommendations for our plan of care, the defined goals, objective data, which I know Hillary's going to talk about here in a little bit, patient progress, education, care coordination, discharge planning, and it also should be payer compliant. And then we'll advance to the next slide. In terms of formatting, what we've seen in, oops, we'll go back one. There we go. In terms of that's okay. In terms of formatting, research indicates that formatting options may help promote readability and accessibility, as I mentioned. So consider implementing bulleted or numbered lists into your reports instead of the use of paragraphs. Again, as Hillary mentioned, we're all growing. That's something that I've had to adopt as well. Developing separate sections for our assessment and recommendations, and then providing clear, concise explanations and implementing plain language. And then again, I typically like to add references to my reports and I do it at the end, but as I mentioned, the research shows us that although references are very helpful for us in terms of critically assessing individual cases, just remember that if you're pressed for time, according to the research, the inclusion of references may be considered a lower priority than some of these other aspects. So overall, in implementing these strategies, we might be able to improve the readability of our reports while also increasing our efficiency in report writing. So with that, I'll give it back over to Hillary.
Yay. All right. So back to me. I've had a lot of caffeine today, so y'all are in for a ride. So we're going to first talk about 5 core principles of high quality documentation. Then we're going to go into some specific strategies you can do to improve your documentation. So the first core principle that we need to address, which Brooke talked about, is accuracy. Accuracy of documentation obviously is important for multiple reasons. We just need to make sure that we're not creating errors. Now, accuracy can be influenced by or improved using some of the strategies I'm going to talk about in just a little bit. But we definitely need to strategize how we use templates and things to facilitate accuracy. We need to be reviewing our studies, guys, to improve accuracy, right? If we're not reviewing, then our accuracy is likely going to be much lower than if we are taking the time to do our frame-by-frame reviews. So there's that. Completeness. We need to make sure that we are being thorough, right? That we're not missing huge chunks of evidence or data that could contribute to the patient's overall picture, right? So we need to be thorough and balance that without getting lost in the sauce of analysis paralysis. And I'm going to give you some strategies about that in just a minute. So we do need to be as thorough as possible. I dare say that my FEES template is thorough. It is very thorough, but the way I've set it up makes it very easy to use. Our reports need to be timely. Our documentation needs to be timely. This is for numerous reasons. Number one, if it's contributing to the patient's medical record and it supports clinical care, then obviously we need to get those reports submitted and put in a timely manner. But also think about it from a liability standpoint. One of the reasons that, clinicians may be deemed at fault in a malpractice case would be that they didn't complete their documentation in a timely manner, or they didn't communicate their findings in a timely manner. So making sure that we are timely and we use strategies to facilitate that is really important. Legibility. Now, this isn't so. Now, I'm of an age where we did paper documentation and charts at hospitals. I'm not going to tell you how old I am, but that's what we used to do. Give me a thumbs up in the chat for those of us who remember doing paper documentation. But legibility isn't just handwriting, right? We all know those horror stories of trying to read doctors' handwriting in the hospitals and things. it's really important for us to not get too jargony, not to get too fancy with our language, to where it makes it really obtuse and hard for someone to understand or to read or to comprehend the information that we're trying to express. So making sure that our reports are as easy to read as possible is a huge, huge thing. And then objectivity. I think in dysphagia, this gets lost a lot because so much about dysphagia evaluation can be subjective, right? So, how do we move ourselves from this subjective, and I think maybe we're better to using really objective measures to the extent that we can, that they're available with our current evidence base, but using as many objective measures to take your perception out of it and to, make it very observable, make it very consistent between one person and the next. So you have that stronger inter-rater reliability if you're using objective, measurable data. It removes bias, it removes that subjectivity. And so we'll talk about this in just a minute. So, with those strategies being said, or those core principles being said, what do we do to actually make our documentation better? Well, there's a lot of things we can do. And so I'm going to give you a little list, and then I'm going to show you a method that I've learned called physiology-first documentation. And these are all things that I think that have definitely helped me with my documentation, and I hope that they help you as well. So the first strategy is going back to what I was just talking about, data, right? Using as much data, as much objective information in your report as possible. And that's because without that, it's really subjective. There's prone to error, there's prone to bias, and we need to take ourselves out of that as much as possible. So what does that look like with fees? We have, considering, compared to what we had when I first started my career, we have a whole pile of things that we can do for objective measures for fees that are evidence-based. So we have the OHAT. If you are not sticking your camera in someone's mouth to take a picture of their mouth and then rating it in your report, you are missing out on a really valuable opportunity with your fees reports. It takes seconds to do it, and it gives that extra information that you can't get on a video fluoroscopic swallow study. You can get it on a clinical swallow eval, but it's something that we should be doing. And I put it in my reports. I put the pictures of their either clean or really nasty mouths. And I have objective data that I can then give to my facilities and say, look, last quarter, y'all's average OHAT was a 3, but this quarter, your average OHAT is a 2.1. So y'all are doing much better. Yay, good, go team. So those kinds of things are really, really valuable. Reflex finding score, New Zealand secretion scale. Oh my gosh, love it. Yale pharyngeal residue severity rating scale, which is always a mouthful. The digest fees, the PAS, FOIS, and FILS are both amazing. And then, of course, incorporating the bolus framework with regards to risk assessment. So those are all things. This is not by any means a comprehensive list, right? This is like the ones I could think of off the top of my head. Now, TIMS also has some tools that can help with whiteout duration, time to whiteout, and there's several other measures that I'm personally learning, and I will be adding to my documentation as I learn and get better with my own documentation. So with the growth. For modifieds, we have a bunch of really cool objective scales and data that you can use. Some of you guys are probably familiar with these. So there's PAS, there's digest, MBSI&P, UES opening duration, the LVC duration, the max pharyngeal constriction, time to most complete LVC, residue, and then, of course, the bolus framework. And there's again more of these than I listed here because there's quite a few that you can use depending on the technology and that you're using to assess your evaluations. I see some chat comments. I'm just going to pop over real quick. How do we access the TIMS data information? That's a Brooke question. So Murray, I'll let you answer that and then I'll go talk about the Murray secretion scale.
Yeah, the Tim's, I'm sorry, the Tim's data can be accessed, like how to do all of those measures that Hillary just mentioned. We actually have a free resource on our website. I'm super excited about it. We launched it a few weeks back, and then Dr. Steele's lab is absolutely incredible and just reviewed all of the information. So it's up on our website. I'll put it in the chat. Sorry, I was responding to somebody else in the chat, which is why I didn't respond immediately. But that's available. And then hopefully end of this week, early next week, we're launching Tim's MVP 6.1. And with that, we are putting out step-by-step tutorials for how to do all of these things. So it won't just be like the static images, there will also be videos.
And they're continually adding things, which just love it. It just makes me so happy that they hear what we need and then they're adding things to make it better. So just can't get enough of it. Okay, so Murray. So the Murray secretion scale. The reason why I like the New Zealand better is because the New Zealand secretion scale looks at the risk of aspiration pneumonia development, whereas the Murray looks at the risk of aspiration development. Kind of see my difference there. So aspiration doesn't necessarily lead to pneumonia development, right? So not everyone who aspirates will develop pneumonia. So I like the New Zealand because it is more sensitive to aspiration pneumonia prediction. And so that's why I incorporate that one in my reports now. I used to use the Murray, but now I've switched to using the New Zealand secretion scale because of that. So yep, and there's the DOS for VFSS. Yep. So I currently use the DOS. I would love to be able to use you know, other things, but the DOS works for us because we have really high inter-rater reliability with all of my endoscopists using the DOS. And that's something that we are going to be working on as a team to see if we can move over um to something a little bit better. Okay. So clinical swallow eval, tons of objective things that we can use in a clinical swallow eval. Some of my favorites, the Yale Swallow Protocol, the oral health assessment tool. You see that one popping up a lot because we know that a dirty mouth increases the risk of pneumonia development. The oral pathogens migrate when they're aspirated and they can colonize in the lungs. So obviously our cranial nerve exam. I don't know if y'all have heard of the test of masticating and swallowing solids, but that is one of my favorites because it is a standardized normed test of mastication that is, it's a little tricky to learn how to administer it at first. I would practice it on like a family member a few times. It's also a free open access resource for you to be able to use. So it's awesome. The bolus framework, again, for risk prediction. The EAT-10 reflex symptom index. Some people still use the MASA, the Man Assessment of Swallowing Ability. I'm not a huge fan of that because it rates pharyngeal stuff that we can't really determine at the bedside. So I don't use that anymore, but I know that there are some people who do it. And I think if you just gave full credit for the things that we can't see, then maybe there is some value in it, but that's not using it according to its intention. Okay, I see a bunch of chat comments coming up. Just checking to see where we are. Okay. So, strategy number 2. This is one that this is a hill I will die on, right? Is quality over quantity. Like Brooke was saying earlier, research, documentation science research supports using very short, sweet, to the point, bulleted language, right? When you have your interpretation or your physiology section as a big old long paragraph, I don't know about you, but I'm ADHD and I look at that and I'm like, do I have to read this whole thing? And I get lost in the sauce. But if you break it up into chunks, all of a sudden my brain doesn't think it's that big of an obstacle to overcome, and I'm able to process the information more. Also, if you break up your sections, as I'll show you when we do my template tour in a minute, I break up my physiology section, my diagnosis, into a few subsections, right? So there's the assessment. I have the oral phase, the in the things that we can observe with fees to the extent that we can with fees. And then I have my pharyngeal with liquids, my pharyngeal with solids, my pharyngeal with pills. So I break things up into subsections with bullets. And that way, if I have someone who picks up my report and they're like, how did this person do with pills? They can, boom, straight to the pill section, and they can see how they did with the mock pills that I trial. Or if they're like, oh, how did they do with liquids? Boom, super easy to find. They're not having to dig through, a mile-long paragraph with extra information that doesn't really need to be there in order to find the information they're looking for. I also bold certain words that I want their eye to be drawn to. That's a way I help with readability. I help bring the reader's eye to the things I want them to pay attention to. If it's super mega big time ultra important, I will put it in red with bold and underlines. Like those who've been in my buildings have seen me document that way. So if it's something I suspect maybe a malignancy or something that needs, pretty immediate attention from the physicians, I will put it all caps, bold red with underlining, right? So that it really stands out when they're flipping through the report. Oh gosh, wow, here's this like red sentence. What is this? This must be important, right? So I'm using the style of the documentation, the document, to draw their attention where I want it. I use physiology-first documentation, which we have a whole section I'm going to talk about in just a minute, to make it very clear and easy what happened with what and when and where. And then the other thing I have to say, documentation by exception, I'm going to talk about that in a minute too, but documentation by exception is basically you only document the things that are wrong, right? So documentation by exception is you list the abnormalities and you ignore all the normal stuff to clear sort of the chaos in a report. And I think it's important to zoom out and to not get stuck in analysis paralysis when we do these reports. I know when I first started documenting, I wrote these paragraphs that, I thought were beautiful. And I talked about, in this swallow we did this, and then this swallow we did this, and then this swallow we did this, and then this swallow we did this. And I counted the total number of swallows in the swallow study, and I counted all these crazy things that nobody cared about. Nobody, unless you're doing research or you're tracking the data for some other purpose, there's no reason why we need to calculate how many swallows are in a total swallow study. Now, if I'm looking at, we tried thin liquid and we tried 15 boluses of thin liquid. And out of those 15 boluses, the patient had aspiration on 3. Well, that's a number that's relevant, right? That's a number that's relevant to what's going on with that patient. But does the doctor who's reading this report need to know that I had 27 swallows in that swallow study? No, you're just wasting time. Unless you're using that data for research or for something else, right? But for most studies, nobody cares. So make sure we're looking through our documentation with that eye of, is this really important to go in here, or am I just putting it in there because I'm a type A SLP who feels like I have to, right? Because I was a type A SLP who felt like I had to, and so I put all kinds of unnecessary things into my reports. And I've gotten much better at sort of filtering out what doesn't need to be in there so that I can focus more successfully on the things that really need to be there. Okay. Strategy number 3, timely. Okay, so there are times when it is impossible to write things when it's fresh on your mind, right? We ideally, in a perfect world, you do your evaluation, you sit down and you document it. But that isn't real life. That's not how it's going to happen every single time. So ideally, you do that. But when you can't, some of the things that you should do is absolutely take some solid notes. There's a couple of things I do. So when I go into a facility and I have, sometimes 4 FEES in that building, or I have a crazy day where I'm having to like boom, 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 like zoom in and out, and then I sit down and write the reports and get them to everybody at the end of the day, which I really don't like to do, but occasionally that happens, right? When those days happen, when your day just gets away from you and you have to wait, using good notes makes the difference. And when you take those notes, it's really important to prioritize what you are writing on because again, time is limited, right? So I only document notes like either a voice note. Most of the time I use like a Word doc and I'll take notes on the things that I cannot see in review. So I'll do things like, the patient was grimacing, like it hurt when they swallowed. I'll document that. Or their dentures were floating around in their mouth the whole time and we ended up having to take them out. I'll put that in my note. I'll put things like, food was falling out of their mouth onto their chest so that when I go back to review it, those aren't things that my ADHD brain may just decide don't belong in my brain anymore and they're just gone forever. So I write those notes to remind me of the things that I can't watch and review. Okay. Everything else you can watch and review. So that's okay. So when you focus on your notes, focus on the things that you can't see and review. And it's going to help you speed through going, oh gosh, was this the lady with the dentures that was falling out of her mouth or was it that other patient? Right? We've all had that happen. And by prioritizing these things, it just helps it go more smoothly. Trust me, I have been there, done that, and it is a process. So Tim's has a really cool feature that since I've gotten Tim's, really finding valuable is in your Tim's review. You can click on the notes thing and you can either do scorecards or you can just do the notes like I would normally put on a Word doc into the Tim's software itself. And it's like right there with your study. So you go to the next patient, you go back to the one that you just took notes on, and those notes are there. So super handy. You can even customize the notes to do all kinds of fun things, which I haven't figured out all of that stuff yet, but I'm really excited about figuring out how to make the notes section work more for me. But that's definitely something to work forward. Software. So use your technology to work smarter, not harder. Brooke talked about this a minute ago. My rule of thumb is that if your technology isn't working with you actively, it is working against you. Now, I have spent years with software that did not work with me. And it is a drain. It is hard to be effective. It's hard to be efficient when your software or your technology doesn't work with you. So it's really important to the best. I mean, sometimes we're in a facility or a place where we can't necessarily just say, hey, I just want to go and get this technology. But we can advocate. We can try to at least move the needle towards having those tools. And in asking for it. It never hurts to ask, right? So maximize what you can use. And that would be like smart phrases if you're in a hospital, if you're an outpatient or mobile, macro enabled templates. Macros are your friends. Oh my gosh, I love macros. You may need to find someone who's like a computer nerd to write them for you because that's what I did. Because I am not a computer nerd person. And then, of course, using Tim's to its full potential, right? Using the scorecards, using the notes, the reporting features, and those things, which is, again, improving constantly because we give them feedback. So, if something's not working for you, you tell them and they actually fix it. What? I tell you, I've worked with some other companies that don't do that. And so this is like huge, right? So use your technology, leverage the technology to make your life easier. And with that comes templates, right? So templates are awesome because they increase efficiency and consistency between providers. Like for me, I have multiple endoscopists who scope with my company, and it is wonderful for me to know that whether I scope someone or whether Rachel Place, hi Rachel, I don't know if she's on right now, but wave to her anyways. If Rachel is scoping a patient, that our template, our report is going to look the exact same, right? We are going to have the same measures. We're going to have high inter-rater reliability because we've designed the template with that in mind. And it makes it a lot easier for the people who consume our product, right? So whether I scope or whether Brooklyn scopes or whether Rachel scopes, it doesn't matter because the template's the same and it's going to look the same and it is consistent. So your good template should include Tim's scorecards, which I am working on learning. They didn't have an OHAT scorecard, so I asked them to make one. So now they have one. So reporting features, we're working on. I'm working on the tweaking my fees template that I'm giving you into Tim's so that Tim's can give it to all of you guys for free. So if you have Tim's, y'all are going to get access to my Tim's report at some point once I work out all the little fine details with it. And then Microsoft macros, drop downs, multi-selects, things like that. The most important thing about templates, and I see this cause people troubles, is you should have it set to where you start with a new template every single time. If you have a template and you're just going in and changing names and like unchecking boxes after you saved it for somebody else, and you're putting new person's information on that same document, you are setting yourself up for massive medical errors. And I've seen reports where it's clear that they did not use a fresh template and parts of the document had information that directly contradicted itself, and it looked like they were writing about two different people. And I'm guessing from knowing that they had a tendency to reuse templates that was like an error that happened because they didn't get a fresh document every single time. And that creates the opportunity for error. If you have error in your documentation, that can lead to really bad things. And so we want to avoid that as much as we can. So, having a central database. So for me, I have a HIPAA compliant cloud storage system set up so that if I'm in a building and I go, like today, I was in a building and I scoped a patient and I was like, wow, that name sounds familiar. Let me look up in my database real quick. And sure enough, I had scoped that patient in December, but the SLP forgot and didn't realize or didn't remember that I had scoped that patient in December. So I was able to be like, oh, yeah, cool. Here's what we did in December. Here's what we do now. And whether it's on any of my scopes, because it's cloud-based and it's HIPAA compliant, that any of my providers or my endoscopists can look through the database of studies that have been done and they're able to see, oh, okay, this Hillary scoped this one twice, or I can pull up a patient and say, oh, Rachel scoped this patient once and Brooklyn scoped this patient once and I scoped this patient once. And we can look at all the reports side by side and, sometimes paint a picture with what's going on with that patient. So external hard drives are a good option for hospitals. You're looking at PACS, your EMR, those types of things. But having a central database is super handy. I know Brooke said that this isn't important, but I'm going to say it is. So citations, I think my personal feeling is that they add credibility. And I'll tell you a story. So I was in a facility several years ago because I've been including references in my reports for a while now. And several years ago, I was in a facility and I had a physician. I put in my documentation, that feeding tubes in this case, I didn't feel would eliminate all of the risk because this patient was aspirating their secretions. There was reflux involved. There was lots of things going on. And I didn't feel like a feeding tube was the magic wand that was going to fix this patient's problems. And so I documented that, feeding tubes don't necessarily decrease the risk of aspiration pneumonia, especially in patients like yada, 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 right? So I documented that. And this physician came up to me and said, "Hey, what do you mean feeding tubes don't decrease the risk of pneumonia?" And I was like, no, they don't. No, they don't. And he goes, "No, they do. That's why we use them." And I was like, "No, they don't." And so I ended up sending this physician a pile of research articles. And that physician was like, "Holy cow. Wow, I didn't know that." So having now that I've had the citations in my report, I have less of those interactions happening because it's like, look, I know I'm saying something that may not be something you've heard before, but look, here's my receipts. So, like, I promise I'm not just talking out of my rear end here. I come bearing receipts. So, if you're in an area where there's not a lot of understanding about what we do or why we do it, like my area, at least in the first many years that I was practicing, having coming with receipts is a great way to say, look, I am not just making things up to make your life difficult. I'm saying this because this is what the current evidence shows, right? And then making sure that your evidence is up to date. So keep your evidence up to date. So keep your guidelines, your evidence, all of those things. Keep your report up to date. Keep it compliant with current issues. So one of the ways that you can do that is to add informed consent language to your reports. This is another soapbox that I will stand on forever. Add informed consent language to your reports. Dysphagiainformedconsent.com has lots of resources for you on that. And then make sure your template is updated frequently with the latest evidence-based practice. I do that fairly regularly with mine. And like changing from the Murray secretion scale to the New Zealand secretion scale, right? As we found something that I felt meshed better with what I was trying to communicate to my physicians, or that helped me help them determine a prognosis or even like risk calculation to the extent that we can, kind of. Those are the things that we need to be adding and keeping abreast of so that we can continue to be as relevant and current with our evidence as possible. And then seeking education that will help you stay current with those things, right? Well, you're here, so congratulations. Everybody give yourself a pat on the shoulders, on the back. You are here. So you're here to improve your documentation. So you're taking the first step. There are lots of opportunities out there. Again, I will get on the soapbox that it doesn't have to be an $800 webinar or an $800 course for you to improve your documentation or to have better clinical skills, right? There are so many out there that are low cost, especially with your state associations. Tim's University, I think Brooke said they put out like 20 to 30 hours of CEs every year, free. Right? There's other websites, Passing Year, there's all these other places that have free or low cost education that you can access that will help with growing your documentation practices, right? And I have to, as a past Louisiana Speech Language Hearing Association president, I do have to shout out our state associations. They often put out low cost or free webinars on topics that are driven by you. So if you want your state association to do a webinar on a certain topic, then communicate that with them. They love that. As a president, I loved it. And it helps them help you, right? And those are usually very low cost. So, definitely get out there and keep digging in. And if you have other topics you want me to cover, then I will find a way to make it happen. And then the last strategy is remember that we are all making continuous progress, right? I am continuously progressing. You can ask any of my referring clinicians. I'm like, oh, hey, by the way, I updated my template again. How often do they hear me say that, right? It's a pretty regular thing because as new things come out, as I learn things, I'm going to be changing my documentation. I'm going to be adding and tweaking or even taking things away that I used to do that I don't do anymore because I learned better, right? And so don't be afraid to change something just because you've done it that way for a long time, right? The whole this is the way it's always done, always been done is one of the worst sentences in our field, right? I on average have a major update to my fees report every year. And I do minor tweaks, here and there, but I'll have like a big total overhaul about, once a year. So feel free to continuously improve and change and get better as you go. So, whew, all right, now we are going to talk about one of my favorite topics. I'm just going to pop into the chat. Um, Website is called dysphagiainformedconsent.com is for the informed consent.
Hillary, there's a couple of questions for
Yeah.
you specifically. So I'll ask them too because I've been monitoring the chat. This person said, what do you recommend in terms of documenting when you speak with physicians about your recommendations and the physician does not agree with you or implements a different plan entirely despite your conversation?
I am so glad you asked that. So I actually have a bullet point in my template that talks about who I gave the recommendations to, whether they indicated to me that they understood those recommendations or whether they were combative or reluctant to acknowledge them. And I have used that in the past when I've had physicians who were, or even other like uh, add-ons or things like that who I gave the findings to, and they were hesitant to support my recommendations for things. And that's cool. That's awesome for them. But if their hesitance or their choice causes a patient issue, I want it to be documented that I said this patient with a large retropharyngeal mass needed to go see an ENT stat. And they're saying, oh, but his O2 stats are fine. He doesn't need to go in. Well, I'm going to put in there that they were, resistant to the information that I gave them. So that if it ends up causing a sentinel event and this patient passes away or something other happens, that it is documented that I gave them that information and what they choose to do with it after that is on them. So yes, I do document that. And it's in my template. So were there more, Brooke, or are we good?
There are quite a few more, but I'll let you keep going and we'll get to them at the end. I'm trying to navigate the ones in the chat as well while you're presenting.
Okay, awesome. Yeah, I'll try to give you guys some time to ask questions at the end. I know it's a huge topic, right? So we're going to talk about physiology first documentation, aka the Brodsky method. So about 2018, I was spending 3 hours writing a fees report. No kidding, like 3 hours to write one report. Not very productive on my end, right? And I kept getting lost in this analysis paralysis and how do I phrase things and like what am I doing, right? And that was the impetus for me to completely rethink my entire template. And having the opportunity to learn from Dr. Brodsky was pivotal in my documentation education process. So he knows I call this after him. So this is called the Brodsky method or physiology first documentation. So oh, there we go. So basically, in traditional documentation for video swallow or a FEES, in an ideal world, these are the things that would be included in your documentation, right? So what being the result happened, so aspiration and penetration with the consistency, where it happened, when it happened, and then the why it happened or the physiology, right? So in a perfect world, in a beautifully written report, this is the typical order that we have been taught forever to write our reports in. And this is an example. So the patient demonstrated aspiration with single straw sips of thin liquid across the dorsal aspect of the epiglottis before the swallow due to decreased tongue-based retraction, decreased oral containment, and respiratory miscoordination. That's pretty nicely done, right? That's how we were taught to do it. But I think we can get better. So the order of importance in documentation, we are taking it back to our communication science part. I know those of us who do dysphagia land don't always like to do the communication land, but we're going to take it back to communication land a little bit, and we're going to talk about grammar. So in the English language, we tend to have the order of importance in our sentences, right? We tend to rank things. It's an inherent automatic thing that we do where we will rank things most important to least important. And it's really commonly done. It's called the inverted pyramid. So they use that for journalism, where they use uh, in paragraphs or in single sentences to sort of guide the prioritize the information being shared, right? So, using traditional documentation with that order of importance, what are we placing the emphasis on? So, we are putting the most important emphasis on aspiration penetration with middle of the road emphasis on the bolus amount and type and the location and the timing. And then least importance, we're kind of throwing it off at the end if it even makes it in. I mean, in the chat, raise your hand if you've seen documentation that doesn't even include that last bit, because we've written so much by the time we get to the physiology that we're done. Mentally, we're done, right? And so I see it all the time where they have aspiration occurred with thin liquid across the epiglottis before the swallow, and I've run out of energy. And so I may or may not include the Y in there. And so that's one of the pitfalls of this. So what should we know that not every patient who aspirates develops aspiration pneumonia. We preach about what is the whole point of a swallow study? Is it to chase the bolus? Is that the whole reason why we're doing a swallow study? Or is it to determine the physiology of the swallow? So with traditional order of importance, we are putting the most importance on aspiration, which may or may not matter depending on the patient's characteristics. And we are putting the least importance emphasis on physiology. So something has to change, right? Hint, it's our documentation. So what if we were to flip it, completely flip it around, right? So we are going to change the order of importance to make the physiology the most important thing and the bolus the least important thing. So we're just sort of rearranging things just a little bit, right? So instead of chasing the bolus, we're going to chase the physiology. So instead of it being like the top, what resulted in what consistency, where, when, and why, we're going to change it to why, which is the physiology, resulted in what, when, where, and with what consistency, right? So we're just changing up that order a little bit. So we go from, the patient demonstrated aspiration penetration with bolus across the whatever, or around the whenever the location when due to physiology, we changed that to physiology resulted in the consequences of the physiology, which are aspiration across the dorsal aspect of the epiglottis before the swallow with insert bolus, right? So we are switching that up. So with doing that, we are placing the emphasis on the physiology where it belongs. We are supposed to be communicating to our physicians that our swallow studies are not about the bolus, but then we are documenting, emphasizing the bolus. So by switching this around, we are subliminally communicating to our physicians, our referral sources, other people who read our reports, that our physiology is the reason why they referred to us, right? So that physiology goes first. Hence physiology-first documentation, I know, right? So an example of that would be decreased tongue base retraction, decreased oral containment, and respiratory miscoordination resulted in aspiration across the dorsal aspect of the epiglottis before the swallow with single straw sips of thin liquid. Same swallow or same physiology was described in both of those, but this puts the emphasis on the physiology. And I think it's just a lot easier to read, especially if you are the treating SLP and you're trying to figure out what to do with this patient, and you go and read a study where they fizzle out before they get to the why. It is really frustrating when you're trying to figure out what exercises to do to help this patient rehab. But if you, as the person who's documenting, switch to this, that's always the priority. That's the first thing that gets documented, is that physiology. So I talked a little bit about this earlier. There's the documentation by exception, and then there's the full physiology description. Documentation by exception, again, is where we only talk about the things that are abnormal. When you start to do like the full physiology description, it gets very, very, very wordy. And so we definitely want to avoid that, right? So these two basically kind of describe the same thing. Um, so documentation by, oh, sorry, they're not the same thing. So basically you don't mention anything that's within normal limits. You only mention the abnormalities. So pharyngeal phase within normal limits resulted in safe and efficient swallowing with all consistencies. Boom. That's a normal swallow. And then another example of it with an abnormal swallow. With the full physiology description, it just gets really wordy. And again, it starts to break that cardinal rule of short, sweet, and to the point, right? And then you're talking about things that are intact, and they're like, why are you telling me this? Like, why do I need to know this? Um, in X-ray reports, they're not talking about, well, sometimes they'll mention a couple of things that are normal, but they're not listing every single thing that's normal, right? So, they'll put a couple of references and stuff that are normal heart size, cardiac silhouette, costophrenic angles, those things, but they're not sitting there breaking down every single thing they can assess in an X-ray to write a report. That would get very lengthy and wordy, so we don't want to do that. Okay. All right, how we doing on time? I think we're doing perfect. Yay! Okay. Recommendation documentation. So we've talked about strategies, we've talked about physiology first documentation. Now let's talk about recommendations. So the number one question I get asked when I'm training an SLP is, how do I decide what diet to put a patient on? Okay. So I'm going to take just a moment to step on my informed consent soapbox, and let's break down this sentence real quick. How do I decide what diet to put a patient on, right? Do y'all see this language? Do you see what we're doing here? How do I make a decision for this patient? How do I put them on something? How do I do this to them? By using this type of language when we ask these questions, we are taking the patient out of the picture. That is not person-centered care, right? We are making decisions for our patients, not with our patients. Now, before you say, but I work in acute care, and there are times when, yes, there are times in acute situations where the medical team has to make recommendations and use interventions within that person's code status to save their life. We're not talking about that. We're talking about Granny who's been in a nursing home for 5 years, right? Or someone who's in home health or who's in outpatient therapy, where it's not an acute life-saving moment, right? We need to really think about how we're talking about that. So I have an entire webinar. It's free. It's available for PDHs on Dysphagia Informed Consent's website. If you want to learn more about that and listen to me go on my soapbox for 2 hours. And then there's lots of handouts and freebies and research articles and ethics case studies and stuff like that over there. But so keep in mind, the way I do recommendations is through that informed consent lens. That informed consent lens of documentation that I teach is based off of my dissertation research, which I have 33 days before I submit it for defense review. And I have spent the last years and 210 plus pages of research looking into this issue. So my research is looking at the barriers and facilitators for shared decision making for people in nursing homes or for SLPs in nursing homes with regards to diet texture modification. So there's a lot of thought that went into this. So, thinking about it from a rules perspective, I don't know. There's a lot of things in dysphagia space that we do because that's how we've always been done, but I don't know where these rules came from. I don't know that they're written. I have not been able to find a rule, a specific guideline or a rule saying that we have to only give the most conservative recommendation as the only option. Um, in fact, all of the guidelines I find at the ASHA level, at the state level, at the federal level, all indicate that it is our responsibility as clinicians to engage our patients when applicable. Again, mind you, not necessarily in these very acute situations, but when applicable, to engage them in shared decision making and person-centered care, to engage them in discussion about the risks and the benefits of the options in front of them, and then help them understand those so that they can make a decision that works for them. It is not anywhere that I have found, if you find it, please let me know, that says that I, as Hillary Cooper, am allowed to put my implicit biases, my goals, my values, and my judgments on another human being and enforce that, right? It's against the law. Anyway, so let's not do that. So diet texture modifications can have repercussions, right? So we need to make sure that we are discussing both the benefits and the risks of those in our documentation so that we can set up either ourselves as the treating clinician or whoever is the treating clinician to do informed consent, right? So what does this look like in practice? This is what one of my reports look like, right? So I give as many options as are relevant. In this case, I have three. I sometimes will give five. There are sometimes, if they're perfectly normal and there's nothing wrong and I have no intentions of changing anything, I give one, right? Like there's no realistic indication that I would change this person's diet because everything is like normal, normal, normal. But I give multiple options. Each option has the texture for solids and liquids. It has strategies for that option, specific to that option. It has the medication route, again, specific to that option. It has risks and benefits. And I have a 17-page handout available on the Dysphagia Outreach Project shop if you want to know what those risks and benefits are, what evidence they came from, and all of that. And then I'll go to option number 2 and have all of that stuff listed, right? I include a little blurb that sets up my treating clinicians to be able to utilize this, right? My job is to assess physiology and then to, based off of that physiology, say, okay, here's some potential options on the table for you diet-wise, right? And then hand that off to the treating SLP, who then gets to help navigate that situation with the patient. Again, without getting too much into a soapbox here, I do include a little blurb on there that because they have the right to accept or refuse medical interventions. Diet texture modifications for dysphagia are inherently medical interventions, so they have the right to refuse it, right? Our job is to make sure they have the information to make a good, educated choice, right? That they're doing teach back and all of the things to be able to make sure that they are truly understanding what they are wanting. So, template examples. All right. So I'm going to give you a FEES template tour. So I am pretty sure that a lot of you have already gone and downloaded my free template. Now, mind you, that free template is locked with its branding. And there's a reason for that. If you really, really, really need the unlocked branding for whatever reason, email me at team@dysphagiaoutreach.org, and we'll talk, okay? And I'm not here to like try to gatekeep things. I want to give you the tools that you need to be amazing and successful. But that's just what my people told me not to give away all my trade secrets, but I'm just like, I want to give away all my stuff. So if you need help, let me know. Okay, so This is my report. So in the beginning of our report, we have, our basic information at the top, right? I have background and history. You'll notice I have these little three dot things, right? The three dot things, these are macros. These are super cool. You double click on them and it pops up a little doodad that you can then,
Hillary, sorry to
yeah.
interrupt you. We can just only see Dwight, which I will drop it.
I can
Yes.
technology,
Yeah.
I swear, y'all. Look, I'm just talking to myself. There we go. How's that?
Yes, now we can see it.
Yay! Okay, let's go back. Okay, so here we have my header, right? So my header has these fun things. Wait, here's something that's really cool with my macro enabled template. I don't know how many of y'all hate doing birthdays. So we're gonna do 01, 01. And look at this age right here. Watch what happens when I click off of that. Boom, it changes the age. I have an age calculator built in because I hate calculating ages. Again, using technology to work for you, not against you. And I have all kinds of fun little macros in my template. So when I type in the name at the top, it shows up in the bottom down there, right? The date automatically populates in the bottom, those kinds of things. If technology isn't working for you, it's working against you. These little three dot things, right? So these are macros. You double click on those and it pulls up an easy input form. You can either click things or you can type in and hit OK, and it inputs the information in there for you. I have lots and lots of drop downs that you can sit here and drop down things, right? So I have, this is basically in the format of a SOAP note. So I have my background, I have my subjective information. This is, what I see when I walk in, when I'm reading the room. In my objective, the first thing you're going to see is consent and a timeout. What is a timeout? For those of you who do not work in a hospital, a timeout is where you take a moment, timeout before you start a procedure to verify that you are doing the procedure on the right person, that you are doing the right procedure on the right person, that you've looked at allergies, you've looked at contraindications, and that everything is green and go to go. So, and then you time out at the end. Yes, he's fine. They're stable. Everything's great. Good. Cool. So that's your timeout. I document that just in case I have the odd every once in a while patient with a little minor nosebleed or something. I document it in the timeout, right? Those types of things. So respiratory status, voice, dentition, oral health status. Again, I have the OHAT score below. I have anatomy. These are some general things that are like sort of smart phrases where I can add to it or I can change it. I can also free type in here and add stuff. I have the consistencies. I have that I can just check. And these are the ones that we gave to the patient today. We have getting to the meat of the study, the physiology part, right? I break it. I told you I break my report down into sections. So I have the oral phase as a section. Now, before someone comes at me, no, you cannot directly view mastication in a FEES report, in a FEES study, but you can gain some information about oral efficiency, right? If it's taking them 5 minutes to swallow one bolus, then, or to transport a bolus back, then you can make a comment about oral efficiency. If the food's falling out of their mouth, then you can comment on that, right? So don't get too lost in the weeds on that one. You comment on the things you can comment on. Mastication, or for modifieds, you can comment on a lot more things than you can with FEES, obviously. Then I go into physiology. So I've changed my report lately to where I have a list of physiology. These are based off of the components of the MBS-IMP that you can see on FEES. You can't see all 17 components of the MBS-IMP on a FEES, so I don't have all of them. But the ones that you can are there. And so I have the basic components of physiology on there. And so I can sit here and say, you know, let's go to that, let's go to that, let's go to that. And then I hit OK. And I have my physiology. And then I have physiology described above, resulted in blah. What I found when I had the physiology listed every single swallow is it got really repetitive and it was unnecessary, right? Most cases, the physiology doesn't change too much from one consistency to another. Like you look at the big picture, zoom out and look what are the deficits that are causing this person issues, right? And then I document those. And then I go through and I discuss with my first documentation what happened with liquids, what happened with solids, and then what happened with medications. You'll notice I have things in here that I may end up not using. So let's say we trialed medication. I use mock pills, little gel caps. So let's say we tried the gel caps with water, didn't go well. We tried the gel caps with applesauce or gloop or whatever you use, didn't go well. So I'm going to delete the sentences, the lines of the ones I don't need, right? So if it's in there, like this one, I wouldn't, I would just delete it, right? Because I don't need it. So I put stuff in there that I may not need. It's easier to delete things than it is to write it out from scratch. Again, using technology to work for you, not against you. I use the food intake level scale. I have, again, drop downs with pre-test, post-test. I use the OHAT. Now, I do normally, I don't have one here, but I will insert a picture of the patient's mouth right here next to the OHAT. Okay, so when you have those really grody mouths that have the secretions built up to limit movement, yeah, it's all going in there, right? And then we have the rest of our scores, our assessment, prognosis indicators that are based off of, I'm working on changing that to be more reflective of the bolus framework. Again, constant change. Here's our options, images, references, done, right? So it's a very, very thorough report, but because I leverage technology to help with what I'm doing, it makes things pretty quick to document. So let me get back to, all right, so I am done with that, and I'm going to hand it back over to Brooke.
Awesome. I know there were a ton of questions. I tried to get through as many as possible, but we'll go through the rest of this presentation and then hopefully wrap up with some questions. So next, we're going to talk a little bit about the importance of reporting for modified barium swallow studies. So I just wanted to give a case study for this presentation demonstrating how crucial our documentation is. So this individual was a head and neck cancer survivor who suffered from multiple chronic issues after treatment concluded, including dysphagia, and both MBS and FEES reporting were absolutely crucial to this patient's access to care. So a couple of key benefits of my reporting included GI consultation for further intervention. My documentation was required for additional therapeutic options, including certified lymphedema therapy services, compression garments, and advanced pneumatic compression. If you work with this patient population, you can attest. Often we need to do a lot of advocacy to get some of these additional treatment options. And then MBS, FEES, and dysphagia treatment notes supported the dietitian's advocacy for changing the patient's supplement via feeding tube to an option that is typically less frequently covered by insurance. So that specific product is Kate's Farm. So I don't know if you all have heard of that before, but our documentation was extremely beneficial in advocating for that. I'll have you advance to the next slide. So as Hillary mentioned, analysis tools such as MBS-INP, Digest, and the rest can help improve our ability to incorporate important data, which aids in our clinical decision making. And I know there was a question in the chat about including some of these analysis measures and how do we incorporate that with plain language. So in my practice, and I know many members of the team that I am on also use the scorecards within TIMS. So this is just an example of what the scorecards look like after you've completed them in TIMS, and then they populate automatically into the TIMS report. I mentioned this in the chat a few times. I do use the scorecards in TIMS. I use the quantitative analysis in the notes features to type, but then I copy and paste everything into Epic because we already have an established workflow within Epic. So there's a ton of different options of how you can integrate TIMS into your workflow if you are using TIMS. But this is just what it looks like in the TIMS reporting. In my own practice, I actually just hit the copy and paste button and then paste it right into my Epic report. So getting back to the question of, physiology first, I use, like I said, MBS, IMP, and Digest typically in every modified Barham swallow study that I do, or I try to. So that MBS IMP provides a nice picture of the impairments, and then Digest, then gives us more information about how are these impairments impacting safety and efficiency, and then adding in that objective component of quantitative analysis is, I think, the nice bow on top, giving us that black and white data, that, quantitative information that we just mentioned. So we'll advance to the next slide. So you can see just a quick example. So this is just an example from a study that I did. I did have consent to provide these pictures. So this just is, again, an example of quantitative and binary data that you're able to obtain via video fluoroscopy. And we know that using both quantitative and dichotomous clinical findings really helps us to comprehensively describe swallow function. So I think including pictures is really great, and doing those quantitative analysis both for MBS and FEES again gives us more of that black and white data that helps to paint a clear picture. An example of this, I had a patient, not this patient that we're talking about, but a patient in the ED a few years ago that I did bedside, wanted to take him for a modified, so I took him for a modified. He did aspirate, but I was able to measure it and gave that information in the report and recommended a regular diet, thin liquids. And I was so impressed because the nurse actually called me. She's like, "Hey, why did you put this patient on a diet? It says he aspirated." But I was able to just show her the pictures because I know someone put that they have Meditech. So I know, shout out to my Meditech friends. You can't put pictures in your report. But we were able to talk about the data I obtained with looking at bolus, the bullet or the residue, excuse me, as a percentage of the bolus, original bolus. So super cool that we can provide that data very quickly using TIMS. So I'll have you advance to the next slide, which just is a quick picture of typically how I set my report with the analysis section using that physiology first reporting, and then just an example of recommendations in that bulleted list. And I do want to mention that I do include citations in almost all of my reports. I know that I mentioned at the beginning of this presentation that some research says that it's low value. I don't think that it means it's not valuable. I just think it might mean in that specific study that the physicians maybe are not always, looking into what we're citing. But I completely agree with Hillary. I've used references many times for patient advocacy. I have also, as Hillary mentioned, we're always, looking to grow in our documentation. I've received feedback over the years that my reporting was previously a little bit overwhelming. So I've tried to restructure how I provide this information in a format that's easier to read. And I moved my citations to the bottom of the report, like underneath my signature. I used to have like in-text citations and then like the full reference list. So anyways, I think it's important that we also listen to the feedback from our team and you're looking at your individual workflow. I know we've had a lot of questions in the chat about specific individual workflow. So again, go back to your team, see what works the best in your specific setting. But these are just, things that Hillary and I found helpful in what the literature is saying. So we'll advance to the next slide. Okay, so as we said, work smarter, not harder, leverage your technology. Implement smart phrases if you have them, report templates that we're sharing this evening. Try to streamline your standardization and objective analysis using technology. So like I mentioned, TIMS is so easy in that regard. If you don't have TIMS, you can also use ImageJ, which is a free NIH provided software. But I know many people do have TIMS, and it was developed specifically for this purpose to increase efficiency while focusing on patient outcomes. And I just kind of want to end with that reporting can be accurate, effective, efficient, and I personally think fun because I'm a nerd both in the writing realm and in speech pathology. So with that, I want to show you just a quick demonstration video because I know there was a ton of people in the chat asking, like, can I see a quick demo of reporting? So let me get this pulled up and then we can answer the questions that are in the chat. One second here. So this is just if I can get it pulled up here. Let's see. Well, let me make this big. Here we go. Here. Okay. So this is just a quick video. Let me start from the beginning for you. Just demonstrating some of the features that are in TIMS. So you can see here, I used one of our measurement tools to assess residue as a percent of the bolus. You can see the scorecards there in my notes tab, which can be opened up and have drop downs and smart phrases. I can use that notes feature as I progress through each series, which is super nice. Like back in the day, I remember handwriting on a chart while I was like at my mobile TIMS. So you don't have to do that anymore. You can have this open and be analyzing. And in my case, copy and paste that information into Epic. You can compare your studies side by side, frame by frame, both MBS and FEES, or in this case, just MBS. And then as you refresh, all of those scorecards are going to populate forward as all of your images. And then any notes you take, as you can see here, populate forward. So in this case, I have that analysis section. So it populates forward and it's going to have those drop downs. So this is all completely customizable. If you have questions about it, again, send us an email at training@tims.com. Happy to talk. TIMS, happy to talk. Hey, I'm just going to use the scorecards in TIMS. I want to get those into Epic or Cerner or whatever. Send us an email and we're happy to jump on a call. So with
So
that,
I was flipping through some of the comments and the questions, and there's a couple that I want to address. So Karen, I think it's Diebler, said, do you feel like when you give multiple options that it's overwhelming to the patient or the caregiver? So sometimes it can be. So I created a free visual aid for you. Download in the Dysphagia Outreach Project shop that it has pictures and you can literally like print them out, like laminate them and then use them as a visual aid to help decrease the overwhelm of the options. You can incorporate it into your therapy and have it be an activity that you're doing that is skilled, because you were talking about decision making, patient-centered care, all of those things. So yes, it can be. Not for my clinicians. My clinicians love it. They love that I'm giving the risks and benefits and I'm setting them up to be able to just copy and paste into their document and to go through their process. But for the patients, it can be. So that's why we need things like visual aids. There was another one that I saw. Timeliness. So if somebody's not filling out a swallow study for weeks or months, yeah, that's a violation. That's no good. So report them. It's bad for a number of reasons. It's bad. And we'll, I guess, open it up. Any other questions?
Yeah, there were quite a lot of options or questions, excuse me. I'll answer a couple about TIMS that I saw, and then there was one specifically about acute care that I can
Oh, yeah.
answer. All the features in TIMS that we showed tonight are included in the software. If you're on an older version of the software, some of these might be unfamiliar to you. We've come out with a lot of different versions throughout my lifetime so far. So we'll be releasing TIMS MVP 6.1 soon. Like I said, probably end of this week, early next week. So yeah, that's if you're seeing something that you're like, I'm not familiar with, just email us at training@tims.com and we can walk you through it. Someone asked, use the REST protocol. Yes, I did the REST training. It's amazing. Highly recommend. Does TIMS automatically update the new software? No, it does not. You actually have to work with your IT to update it. And we do send out a ton of emails telling people, hey, there's a new software available. So if you're wanting our newest software, just give us a call. Like I said, end of this week, early next week, and it should be out. There were some questions about giving multiple options in acute care and people asking like, is this really time consuming? How do you navigate this? I think that's like a whole webinar in and of itself. Speaking for
Acute care
myself.
own beast. So in acute care, sometimes we have to move very quick. We have to make very fast decisions to protect patients' life and well-being. And so we may not have the time to have those conversations in acute care. Now, once they step down and you're preparing for discharge, maybe that's a time for having that conversation. But when they're in the ICU and they're not stable, that's probably not the best time to be having that conversation with them.
Yeah. Yeah, I think it's patient specific too. I do my
Yeah.
absolute best in acute care to have those conversations. And if the patient, is not in a place that they can medically have those conversations, then, talking with whoever is making medical decisions for them. But it's definitely more challenging, I would say, or at least in my experience working in acute care, inpatient, outpatient, acute care is a little bit more challenging. Do, do, do.
What do I use for pills?
Okay.
I use empty gel caps. So I buy them in bulk on Amazon. There's different sizes that correlate to different medications. So I use size 5, which is about a Benadryl size. And then I use a 00, which is about the size of an Augmentin. So I use those as and they work fine as empty pills. I've tested them myself and they're fine. But I find having two different sizes sometimes gives me a lot of insight. Sometimes they do better with one over the other. And so.
There were some comments or like questions about the digest table and MBSNP table that I shared. Those are from Tim. So that's just the straight up Tim's scorecard. Super easy to score. It takes just a matter of seconds. And that can be copy and pasted directly into your EMR or, right into your Tim's report. I also saw some people were pumped to get Tim's. Super excited for you all. You'll either work with Shannon, Megan, or myself, we're all speech pathologists. So everyone gets, complimentary training with Tim's, which is awesome to hopefully help implement some of these tools. Because I'm seeing a lot of people writing like, how long does this take you to write these reports? That's again the beauty of Tim's. Whether or not you're using the reporting feature, a lot of these things that we're talking about, the analysis tools, quantitative measures, and even like that little notes template, you can have a template in your Tim's and be documenting at the bedside on your fees cart and then send it to your Tim's review and copy that into Epic. So just super easy ways to implement some of these things. And Hillary, somebody asked about how long does it take you to write up your fees report? I know for me,
It
for like
it
a fees or an
depends.
MBS, it varies.
It varies depending on the complexity. Like you have those that are easier. It's like very cut and dry. This is very easy, very normal, not a whole lot to talk about. And then you have those that it's like, holy moly, this was a beast of a study, and I was in the nose for 27 minutes, doing an entire meal, and we were trying strategies and cups and things and all the things to try to figure out. Those take me a while. So I would say on average. For me, I am in the door, out the door, an hour and a half for a fees. That is unload my equipment, roll into the building, clock starts, right? Roll my equipment out, clock in. So I would say on average, I'm an hour and a half. So probably 30 minutes to 45 minutes of that is patient, like in the room time. And then the rest of it is documentation, communicating findings, chit-chatting with my SLPs because I'm a chatty person, and that stuff. So I can get in and out faster. I like to talk to people. So if I have to get in and out quickly, I can knock it out quicker than that. But I don't like to rush myself with patient prep and I don't like to rush with documentation. So
So I know we did not get to all the questions. There are a ton of questions. So happy to stay on a couple more minutes and answer some of these, but if you need to jump, feel free to jump off. I'm gonna quick copy and paste those not references, the links that we talked about, into the chat so you can grab those. And then we'll keep going with some questions here. So let me scroll up here so I can find where I put that. And I keep seeing questions about like training. Training is free with Tim's, like it comes with your Tim's. You can reach out to us at any time,
and I
and
will
get
give a shout
training.
out to Shannon. She has the patience of a saint, dealing with my ADHD brain, who is not a technology savvy person, going, wait a minute, didn't you teach me? You did teach me that. Okay, I forgot it. Now I need you to teach me again. Shout out to Shannon. She's amazing. Shout out really to the whole team, for helping me. And one of the things that I just have to give credit where credit is due is, as a power user of like, I write a lot of reports, right? There's a couple of things that I'm like, man, it would make my workflow better is if it did this. And I was like, hey, Brooke, what if it did this. And they were like, oh, that's a great idea. And like some of those things that I've already recommended are in this next update. You guys, that is mwah, chef's kiss. Like, that's awesome. So I just have to give credit where credit is due that if you make recommendations, they actually incorporate. If you have a problem, they will fix it. That's awesome. It makes me very happy.
Yeah, I
So
saw somebody said is training free for those in Canada. Yeah, so Tim's is worldwide. You know, we have people in Ireland, Canada, um, there's like all Japan, like put everywhere using Tim's. It is part of the like it's included in the cost of Tim's. So just send us an email at training@tims.com. We're happy to jump on a call with you and go through that. And to Hillary's point too, I'm like so excited for everybody to get the new software because there are features in there specifically regarding quantitative measures, which I've been learning out about for 2 years now, that came from direct feedback from clinicians. For example, summation of scores. So now when you measure multiple areas of residue, it adds it up for you automatically, like so much faster. And then some of the automated tracing tools are more accurate. So if your fluoro isn't as high quality in terms of clarity, Tim's will hopefully be a little bit better for you in that regard in terms of defining the bolus and whatnot. So super great. If we didn't get to your questions, Hillary, I don't know if there's any that you're seeing that you can answer. But
no,
I know
I
there's a
just
lot of
want to
questions
thank
about our acute
everyone
care
for
guys.
spending time on a Tuesday evening with us. It humbles my soul that 488 of you came to listen to us talk, and that just makes me so happy. And for those of you who donated, thank you from the very bottom of my heart for supporting such a great, I'm biased, but a great cause of the Dysphagia Outreach Project. And that support helps keep us able to do things like this, right? So, again, like we said in the beginning, if you guys have other talks that you want to hear, let us know. I love to give away knowledge for free. It makes me happy. It's like Christmas, but the joy of watching people unwrap a present. I love it.
I'm gonna put the or I'll send it out via email. I see people are commenting saying, "Can I have the link to donate?" I'll put it in the chat here real quick,
Or
but
you
I
can
will
go to
also
it's when you go to dysphagiaoutreach.org, it's on the homepage. It's like boom, right there in the front. It's like first thing you see. I know, I did that on purpose. You have to scroll down past the donation page to see the rest of the website. It's on our homepage. So it's right there.
awesome. And last thing, the slides and the webinar replay will be up on the Tim's website by tomorrow. So you can jump on there, rewatch this, download the presentation, and then you can go to Hillary's website and download any of the templates for free for the next 7 days. So with that, I will let everybody go this evening. Thank you all for joining us, and we will see you hopefully at our next session on Thursday evening. Bye, everybody.
Bye.